vast majority of discharge problems are not clinical at all. They are social. Patients homeless, patients do not, maybe they have a place to live, but they don't have the home supports because now they're hemiplegic and can't get around. And I could go on and on about that. Whereas the acute care hospital operates in a dichotomous way. Do you need to be in the hospital or do you not? Which doesn't take into account the frequent inadequacy of post-hospital system. And the discharge planners are often have to kind of after the fact kind of put that together. It's not much of a stretch to say that psychiatry should be involved in every complex patient, even if for no other reason than just to sort it out and try to direct what kind of services the patient needs, as opposed to try to expediently discharge them for the inevitable recurrent return to repeat the same process.
How do we, and this, again, like ideally, and if I'm hearing you correctly, we have some psychiatric worker, caseworker, or
Mhm.
social worker who's triaging every case that comes into the hospital to some
Mhm.
extent. How do we scale that when we know that we have such a huge shortage?
Well, of course, that's a great rhetorical question, right?
Yeah.
Well, I think there's some. Uh, I never know if I should be optimistic about this or not, but there's some room for optimism.